My name is, again, Dr. Sebastian Kliszewicz. I'm a physical medicine and rehabilitation doctor, PM&R. I work at the Spine Center on Colonial and I-75. I'm an osteopath, so when I did my osteopathic training, we had a course, a biochemistry course, and we did 1 hour on food and nutrition. Then I went into my internship. Nutrition was not included. In my residency, I did my residency in Milwaukee. Nutrition was not part of our training. But then I started getting interested in nutrition, and I started reading, I started attending more courses. And I've been incorporating nutrition in my practice ever since I've been practicing for the last 4 years. And as I said, when I came out here, I thought I was by myself. And then as I met Sal, I realized there's a large group of us. And now we have a committee, Food is Medicine Committee. And Sal is going to come up and talk to us a little bit later. And this is a committee that meets, well, I think we're meeting now every 6 months and maybe even more frequently. You are more than welcome to become part or get involved in the committee. You're more than welcome to find out who's involved in the committee, who's out there in the community that practices food as medicine. As you know, this is a movement and it is growing, so we encourage growth. And again, thank you for attending today. So I'm going to talk a little bit about how is nutrition involved in chronic pain. And as I said, when I came here first, chronic pain, what are you doing doing nutrition? And I am not, as I said earlier, I'm not a chronic pain management doctor. I'm a rehab doctor. And rehabilitation, we try to rehabilitate the pain. We try to figure out what is causing the pain and can we help you. We do that through exercise, through other means. And I include nutrition because we want to try to heal the body. And the best way to heal is to create health. And the way to create health is how can we get all those nutrients and then get all the right things in your body to create that health. Recently, the American Physical Therapy Association came out with their newest guidelines. And in their guidelines, when we're treating chronic pain, musculoskeletal pain, or neurological pain, the physical therapists are encouraged to include nutrition guidance with their patients. So now it's not just the physicians, not the dietitians, it's the physical therapists. It's everyone who's involved in the patient care should be involved in nutrition. Because as Jose mentioned earlier, we cannot do this on our own. We cannot do this as one physician, as one dietitian. We have to work as a team. So we're going to talk a little bit about oxidative stress and what its role is in pain disorders. We're going to talk about how diet influences and how diet and antioxidants are used to treat pain and oxidative stress. We're going to talk about what foods have different antioxidants. We're going to talk about some of the absorption of antioxidants and also what are some other diseases that are related to food that contribute to chronic pain. So let's talk a little bit about oxidative stress. Who's heard of oxidative stress in the past? And I know Dr. Jose mentioned it, so did Brian, Dr. Tashner. And oxidative stress is basically where your body produces free radicals that attack other parts of the cells, like the DNA, the different proteins, the different lipids. But oxidative stress happens through either physiological or pathological metabolic processes. And then what happens, what our body does is uses antioxidants to neutralize them. So you have these free radicals that are produced by metabolic processes, either normal or pathological, and then you have the antioxidants. And if there's a pretty good balance, you don't have much oxidative stress. But if there's a lack of balance, if there's too much free radicals versus antioxidants, then the body or the system or the cell is in an oxidative stress. And that increases the aging of the cell, increases aging of all the different proteins. And oxidative stress has been shown to be part in most chronic diseases, not just pain diseases, but atherosclerosis, Alzheimer's, as Jose mentioned, cancer, fibromyalgia, arthritis, and everything else. But not all oxidative stress or free radicals are bad. Our macrophages and neutrophils produce reactive oxygen species when they're faced with bacteria and other pathological processes. We use the free radicals to kill them, zap them. And then the body uses the antioxidants to clean up, to kind of scavenge them. So low doses of reactive oxygen species are actually helpful. They're necessary to help us be alive. But it's the problem when the reactive oxygen species overtake our body and we go into oxidative stress. So some common oxidants are superoxide, hydrogen peroxide, and we'll mention some of those a little bit later. And then we have the antioxidants. You can divide them up into the non-enzymatic and the enzymatic antioxidants. Those are the non-enzymatic ones are the scavengers. Those are classically taught to us as ACEs, the vitamin A, C, E, and S, but we're realizing there's thousands of different antioxidants. So it's not just these guys, but this is a nice way to present it to your patients, nice way to remember. The ACEs are our non-enzymatic scavengers, the ones that are going to clean up those free radicals. But you have other things like alpha-lipoic acid, glutathione, as Jose mentioned earlier. You got all these different phytochemicals and flavonoids, which are the pigments in these fruits and vegetables that are the antioxidants that will protect us against the free radicals. And then you have the enzymatic antioxidants. Those are the catalyzers. Those are the machines that are producing, that are basically trying to clean up all the free radicals and all those messes. Those are the glutathione peroxidase, catalase, superoxide dismutase. And then you need some cofactors, some helpers, like the zinc, copper, and other minerals. So how do we measure oxidative stress in our body? There's multiple assays. You can measure the serum or tissue levels of antioxidants like vitamin C, vitamin E, glutathione. We can check the total antioxidant status or total antioxidant capacity. And there's multiple assays to do that. The ORAC is one common one, basically oxygen radical absorbance capacity. How much can you absorb those free radicals? The total oxidation status, the MDA T-bars that checks the oxidative stress, basically how much oxidative damage is done to the lipids in our body. And basically we can measure that and tells us how much free radicals are present. So a lot of assays to measure that. So what can increase our oxidative stress? Obviously this is a food is medicine lecture, so food, the wrong foods. Today we're lucky that Larry Altier gave us foods that do not increase our oxidative stress. They will help us. They will actually decrease it. So again, if you see Larry, make sure you thank him for that. Other things like stress, or Jose mentioned smoking. It can smoke your cells away. Go ahead. Strenuous activity. I read an interesting paper too recently on chiropractic adjustments. So you get those adjustments, and afterwards they check their oxidative stress. And again, because of those mobilizations, the body went into oxidative stress. Not that it was bad, but it was something that the body was reacting to. Same thing with strenuous activity. You go run a marathon, you're going to be in severe oxidative stress afterwards, and your body's got to be able to recuperate from that if you have enough of the antioxidants. So wrong food, right? We're here to talk about food as medicine. Wrong food can definitely cause oxidative stress. This is a good study looking at patients who ate the McDonald's meal, and within 1 hour to 2 hours, their antioxidant levels just plummet. And this study also looked at, hey, what if we eat a whole bunch of wild blueberries? Can that change? So the line above here looks at people that actually ate a bunch of blueberries with that nasty McDonald's meal, and their oxidative stress wasn't so severe. So if you're out there eating those ribs or whatever Dr. Tashner talked about, or the sad American diet that Jose talked about, afterwards, within 1, 2, 3 hours, your antioxidant status goes down. You're in oxidative stress. So you do that in the morning, you do it in the afternoon, you do it in the evening, and you're just constantly in an oxidative stress. Not if you eat blueberries, though. So why do we talk about oxidative stress? I work with patients in pain, and I work in, as I said, in the spine center and rehabilitation. Why do we care so much about oxidative stress? Well, oxidative stress equals inflammation. And how do we always treat pain? Anti-inflammatories, right? Everyone wants to be put on NSAIDs, ibuprofen, naproxen, whatever it is to decrease your inflammation. Turmeric, which I like, one of my favorites. Inflammation is very often pain, but oxidative stress is actually inflammation too. Multiple studies looked at people and their oxidative levels and how does it correlate. So the more oxidative stress, the higher the high sensitivity CRP. The less total antioxidant capacity you have, the more high sensitivity CRP. So oxidative stress is inflammation in our body, and Brian Tashner mentioned that as well. So now how does oxidative stress, which is inflammation, influence pain? So we're going to talk about multiple pain syndromes, osteoarthritis, rheumatoid, fibromyalgia. Jose already talked about it a little bit. Neuropathy, myalgia, even tendinopathies. Oxidative stress and inflammation is involved in these. So let's look at some patients with osteoarthritis. This is a good study in India. Looked at patients with osteoarthritis, and they measured their oxidation stress or oxidative stress in their serum. So the patients with osteoarthritis, if you look at them compared to the controls, had more oxidative stress, had less ascorbic acid, patients had less vitamin C, less glutathione, less catalase. These people are or glutathione peroxidase. So these people that have osteoarthritis, when you measure their blood, they have less antioxidants. They're more in an oxidative stress compared to controls, compared to people that do not have osteoarthritis. Okay, so now what about the actual synovial fluid? So we know that their blood shows us these people are in oxidative stress. What about we stick a needle in their knee and draw up the fluid? Is there more oxidative stress? So in this study, they looked at it and they found that the enzymatic antioxidants, the ones that are doing all the job, are actually working a lot harder. So people with arthritis, their enzymes, their antioxidant enzymes, were working really hard compared to the people that don't have arthritis. And then if you look at the patients that have severe arthritis, they burned out. Their antioxidants are burned out. So patients with severe arthritis have less antioxidants in their body. They have less ascorbic acid, less glutathione. Severe arthritis, it's very minimal. They burn their antioxidants out. So again, we looked at their serum. They're drawing it into their joints. They're trying to use it as much just to protect them. And after a while, when it's bone-on-bone arthritis, we're done. Their antioxidants are just used up. So how does oxidative stress actually influence the cartilage? And there's multiple studies that looked at the cartilage cells, the chondrocytes, and when there's more free radicals, the chondrocytes don't do very well. Their telomeres shorten, and we know telomeres determine the lifespan of our DNA. So the telomeres shorten, the DNA starts breaking up, and then the chondrocytes start dying. So they're not producing the cartilage that we so much need for our knees and for our joints. But if you give them some vitamin C, give them some antioxidants, guess what? These telomeres are like, yes, I like this. They're producing all these proteins, and they actually thrive. So, what about in people? So, we know that these telomeres are, not doing very well. We know that these people with arthritis have less antioxidants, and they're burning them out in their knees. What if you change their diet? Does it affect their arthritis? And yes, intake of vitamin C, this was from a Framingham study, decreases the pain in osteoarthritis. So these patients, all of them had arthritis in their knees, but the people that had more vitamin C in their system, the people that were eating foods with more vitamin C, had less pain. Their arthritis may have not looked much different, but they did not have as much pain because those antioxidants were protective. They decreased the inflammation. We talked about inflammation being part of it. High intake of antioxidants actually decreases your cartilage loss. So they looked at the knee joint space in patients with arthritis, and they followed them for several years, and they wanted to see, okay, is there a difference in how much cartilage you actually lose? And yes, the people that were consuming the most antioxidants, and vitamin C is the one that they measured, guess what? They did not lose as much cartilage space as the people that were eating less. And then what about the people, okay, so I had a fracture of my knee. I'm going to have arthritis. There's nothing I can do. Well, no. Multiple studies looked at animals, models of fractured knees, and then they measured, how much cartilage loss are you going to have, how much arthritis are you going to develop if you have high antioxidants versus low antioxidants. Guess what? The animals on the high antioxidants diet did well. They actually recovered much faster. They had less osteoarthritis, even from this traumatic knee injury, compared to the people compared to the animals that were eating the fatty meals. So we talked about the obesity. We know that obesity increases weight on your knees. So then you have more weight, you destroy your knees a little bit more. We know that the fat cells produce inflammatory chemicals that go down to your knees. We know that the fat pad, actually, of the knees of people that have obesity, a fat pad produces a lot of inflammation, which increases the inflammation inside the knee joint. But what about post-traumatic injuries? So again, multiple animal studies looked at animals that had a fracture through the knee, or you destabilize the knee by injuring the ligaments that support the knee. And let's see what happens. So again, the mice and the animals that were turned fat or diabetic, they went on full-blown osteoarthritis. But the ones on vitamins or nutrients and high antioxidant foods, they did okay. Very low arthritis compared to the fat and diabetic mice. So we know that level of inflammation equals the level of pain. So if I have more inflammation, more high sensitivity CRP is elevated in my blood, that actually equals more pain. So when they looked at patients with arthritis who had severe arthritis, the number of the pain scale and the number of painful joints was actually correlated to their high sensitivity CRP. So more inflammation, more swollen joints, more pain. And interesting, the severity of radiographs does not necessarily always correlate with inflammatory markers. I have patients all the time come in and say, hey, you know, I have this, my knee doesn't look like there's much arthritis, but I have so much pain. And then there's patients that have, you know, very ugly looking knees or elbows or shoulders, and they don't have much pain. So it's not necessarily the radiographic findings that will tell you how much pain the patient has. It's more how much inflammation they're having. What else is going on in their life? So here's a good case to illustrate that fact. So this is a bodywork therapist. I took a course in visceral manipulation once, and I met this bodywork therapist, and she was, I don't remember, she was in her 60s, 68, there we go, 68-year-old female. She completed 17 marathons, climbed the Alps, and at the time she was actually training to climb Mount Everest at 68. She was healthy, she never had any pain, she was doing just fine, and on her training she tripped and fell and hurt her knee and had a swollen knee. So she went to the doctor, got some x-rays of her knees, and the x-rays showed bone-on-bone arthritis. Okay? At 68, very active, didn't have any pain, but had bone-on-bone arthritis. She was a vegetarian. She had a very good, clean diet. She ate organic. Her diet was full of antioxidants, full of healthy foods. She didn't feel the bone-on-bone arthritis pain. She found bone-on-bone arthritis pain when she went, or I'm sorry, she found bone-on-bone arthritis when she had her knees x-rayed because she fell on her knee. But again, she didn't really have much pain because the inflammation was controlled with her diet. So inflammation starts in our gut. Which one of these you think is going to cause inflammation, right? And I tell this to my patients every day. And I wrote articles on this, you know, we can control inflammation right here in our gut. You can either make a choice. I would like to have inflammation today, or I can say, no, today I'm not going to have inflammation. I'm going to control my pain. So we prescribe nutrition every day to control inflammation. So what about rheumatoid arthritis, right? That's an inflammatory arthritis disease. There's nothing I can do, right? Just take steroids and all these other immunosuppressant medications and hope things are okay. Well, no. Rheumatoid arthritis is affected by our level of antioxidants. So this is a nice study looking at 40 patients with rheumatoid arthritis and 20 controls. And they put 20 patients on the typical NSAIDs and placebo and 20 patients on antioxidants. So very interesting. Again, the control group is patients without rheumatoid arthritis. Their total thio, we're looking at how much antioxidants they have, glutathione, vitamin C, is much higher compared to the people with rheumatoid arthritis. So these people with rheumatoid arthritis, they are in oxidative stress. They have low antioxidants, and they have a lot of free radicals, right? So then you put them on a bunch of vitamin C, A, and E, and unfortunately, with a lot of these studies, we can't, or they couldn't use food because it wasn't a controlled double-blinded study, right? So they had to put them in pills. But we know food has the same components, if not better. So after treatment, you can see that these patients on the vitamins, their vitamin C, glutathione, and total thio increased. Okay, they improved. They have less oxidative stress. Okay, so that's great. What does that mean as far as symptoms? Well, it's huge. It means a lot. So now these patients, after treatment, you look at their rheumatoid arthritis disease activity index, and the group 2B, which was the one on the antioxidants, they had the least activity. They were feeling the best. Okay? These antioxidants were helping them cure, or maybe not cure, but definitely control their rheumatoid arthritis pain and all of these symptoms. Obviously, I'm in the spine center, so I see inflammatory spinal diseases like spinal arthropathies, which is like a rheumatoid arthritis of your spine. So this is a nice study that looked at 50 patients with ankylosing spondylitis, which is the rheumatoid arthritis of your spine, and looked at their CRP levels and other things, and looked at their antioxidant status. And it's the same thing. They found that these people with ankylosing spondylitis had higher CRP, we know that. They have more oxidants, total oxidative stress, and less antioxidants. So these people are in a constant oxidative stress. And then here we go, talk about rheumatoid arthritis. So this is a nice study that looked at 26 patients put on a Cretan Mediterranean diet. That's like the oldest Mediterranean diet, very high in fruits, vegetables, olive oil, fish, organic, and then versus a standard Swedish diet. And then for the first 3 weeks, these patients got their meals in the hospital, then they went home. Things changed a little bit, and then they were measured again at 12 weeks. And very clear, significant changes as far as their pain, their symptoms, their stiffness, their swelling of their joints. 12 weeks, the patients on the Mediterranean diet were doing much better. Same thing if you look at their disease activity score. These patients have improved, just changing their diet. Their medications, other things have not changed. Patients tell me all the time that what I eat makes a difference, or well, maybe not all the time, because I do have a selected few patients. People seek me out for the things that I do, so sometimes they come in and tell me, I've changed my diet and things have improved. And patients tell this to us all the time, and sometimes we forget, we don't listen. So we need to listen to our patients. This is a really nice study that looked at rheumatic disease activities. This was a questionnaire study in Norway. Looked at 742 patients. And they asked them, does diet affect your rheumatoid disease? A little bit, yes, or great influence. 37 patients with rheumatoid arthritis said great influence on their disease. Juvenile, ankylosing spondylitis, psoriatic arthritis, fibromyalgia. 50% of patients with osteoarthritis said, yes, diet has a great influence on my symptoms. Some of the things that these patients reported were negatively affecting their symptoms: meat, wine, alcohol, sometimes coffee, sweets, sugars, even citrus and apples. So this is a nice example that, we think that some foods are very healthy for everyone. There's definitely individuality. Some people don't do well with citrus. I take patients of strawberries. Why would I do that sometimes? Or tomatoes. Those are high histamine foods. Or patients that are allergic to nightshade vegetables and increases their pains. People are individual. Not all diets work for everyone, and we just have to kind of tailor it. So, some vegetables may be good, some vegetables may be bad. Some people don't do well with meat, some people do better with meat. These patients that did the restrictive diets, 46 of them reported they had less pain when they did the restrictive diet. 36 had less joint swelling. 15% of these patients with rheumatoid arthritis and ankylosing spondylitis actually did fasting. And 65 of them reported less pain and stiffness, and 50% of them had less joint swelling. We do this in our clinic too, and I do this personally too. Ever since I read Brain Maker and Grain Brain, which I strongly recommend by Dr. Perlmutter, I started incorporating fasting into my lifestyle. And I fast about 4 times a year, and I do a 36-hour fast. I have my dinner, then the next day I don't have breakfast, I don't have lunch, I don't have dinner, I get a little irritable, and then I don't eat anything till the next morning when I eat breakfast. So that's my 36 hours. But it's interesting what happens. In the morning, I get a little hungry and angry and maybe a little bit irritable. By afternoon, you get really clear. Your mind becomes extremely clear. You get into that ketogenic state that Jose was talking about. You're starting to burn a little bit of fat in your body. And it's amazing how it kind of resets your body. And it does that too with people with pain. It's any rheumatological disease, if you can do a fasting maybe every 3 months, it really resets their whole energy system. It resets the mitochondria, as Jose mentioned earlier. So here's a case of a 62-year-old patient who came in to our clinic with a lot of back pain. Back pain was present most of his adult life. He had some physical therapy in the past, which helped a little bit, not too much. Pain on an average was 6 out of 10. He was walking around in pain all day long, every day. And it would get up to 9 out of 10 at most days. And he used to work out in the past, and he can't. He can't even exercise. He can't walk because he had so much pain. He used naproxen on a daily basis, and we diagnosed him with ankylosing spondylitis. You can see his spine is fused. This is his lumbar spine. Here's his cervical spine. He is fused. Yeah, he's standing upright. He's a happy guy. He's motivated. He's Italian, too. Which is going to make a difference in how we treated him, or at least I thought I was going to have a harder time treating him. So what do? We put him in physical therapy with Jessica, and that kind of underlines one of the points that I mentioned earlier. In my clinic, I have several therapists who are trained in food as medicine. So when they see me, when the patients see me, they get the nutritional counseling, and then when they go to therapy, do their exercise, guess what the therapists are doing? Well, how is your diet? You know, they're talking to them about their diet twice a week for 6 weeks. That's a strong punch of diet. And they do the motivational interviewing, as Jose mentioned earlier, as part of the, we don't want to offend these patients. So back to this patient, he was doing physical therapy with Jessica. We put him on an anti-inflammatory diet, also put him off gluten, which I thought was going to be really hard. Again, the Italian, he got off pasta. It was amazing. He was making pasta out of squash. We put him on some turmeric. We gave him a belt to help him out on his bad days. And we had a weight loss goal. 2 months later, no pain most of the time. He was walking around. He was back to exercising. He lost 12 pounds, and he was feeling great. And he was making pasta out of his squash. So what is our arthritis prescription? It's not a prescription pad. It's not NSAIDs. It's not ibuprofen. In our clinic, it's anti-inflammatory diet for rheumatoid arthritis or any kind of arthritis. Any of our patients with pain, we work on decreasing the inflammation. And as I said, it's very individual for every patient. Not everyone is going to go vegetarian. Not everyone's going to go gluten-free. But we prescribe diet as part of their prescription for arthritis. So let's talk about fibromyalgia. Jose mentioned quickly that fibromyalgia patients have a mitochondrial dysfunction, but they are in oxidative stress. These people have a lot of free radicals, not too many antioxidants. This is a good study looking at 20 patients with fibromyalgia versus controls. Their antioxidant capacity of fibromyalgia patients is less. Their peroxide is increased. These people are in oxidative stress compared to the controls. And not only that, when you look at their pain scale, from 1 to 10, how much is your pain? The people that had more oxidative stress, they had more pain. And people, so let's look at, so this is the antioxidant capacity. So people that had less antioxidant capacity, they had more pain. And the people that had more antioxidant capacity, the people that had more antioxidants in their system, they had less pain. So again, oxidative stress does influence your pain in fibromyalgia. Here's another, actually let me see. Yeah, this is another study. Again, looking at 30 patients in India, controls versus fibromyalgia, same thing. Lipid peroxidase in the fibromyalgia patients is increased, so that, again, more oxidative stress. Catalase is decreased. Their glutathione is decreased. So these people are not, they're, again, in an oxidative stress. They're not taking in enough antioxidants, or they're not producing enough of them. And it actually correlated with their fibromyalgia impact questionnaire. The more oxidative stress, the more symptoms. Here's a nice study looking at a raw vegetarian diet. This is interesting. They said raw vegetarian diet, but they were allowed to eat animal protein once a week or less. So semi-raw vegetarian diet. These 30 patients, only 20 of them actually were able to complete this study. That's a pretty difficult thing to do for a lot of patients. They were eating fruits, seeds, carrots, juice, grains, nuts, and as I said, proteins. There was a 40% reduction in their fibromyalgia impact questionnaire. So if you look at the middle over here, this is before they started. Most people where their fibromyalgia impact questionnaire were kind of right here and more on the higher end. The larger the number, just like the VAS scale, the worse they're off. And at the end of the 7 months, look at that. Most of these patients were on the left here, where their symptoms were much decreased just with the diet. But this study underlines another important fact, that 20 patients were able to finish this. So it is very difficult. You need a large team, large effort to try to help these people change their lifestyle. There's a reason why they are where they are, and it's not that easy to have them change. So as I mentioned earlier, not a vegetarian diet is not for everyone. For some people it does very well. For some people, actually, I had people who failed pretty poorly on vegetarian diet. When I stopped eating meat, I got worse. I've heard this twice, actually, from my hypermobility patients, people that have collagen disorder, like Ehlers-Danlos syndrome or just benign hypermobility, and they have pain everywhere. They're dislocating their joints. I found out that they don't really do well on a vegetarian diet. They need the meat. They need those proteins to keep on rebuilding that collagen fiber. So we need to be, again, cautious with who we're treating and what is the best diet. I started reading a new book. It's a type blood diet or blood type diet. Who's read that in the past? It's interesting that he talks about blood type O, which is the oldest type. This is the hunter and gatherer blood type, and they do better on the paleo-like diets. This is more from observational studies, while the people that are type A, which are more a bit later in our history, they do better on the grains and the other more vegetarian diets. So, there's a lot of different diets out there, and we need to be understanding that not everyone's going to do well with the one that we think is the best. A lot of studies that looked at the vegetarian diets versus none looked at, okay, here's a vegetarian diet versus a standard American diet. So yeah, it's very easy to make that look so much better. But we got to understand that not all meat, not and all fat is created equal. Just like Jose mentioned, we need to have a specific ratio of omega-6 versus omega-3 fatty acids. 1:1 or 2:1 is a pretty good ratio, where in American diets it's 10:1 to 25:1 of omega-6s versus omega-3s. And omega-6s, again, are the pro-inflammatory. Omega-3s are the anti-inflammatory. And omega-6 are found in processed oils, corn, soybean, sunflower oils, animal products, which are the grain-fed animals. Even the wheat has omega-6 fatty acids. So, most of these standard American diets that include French fries or fried foods, these are fried in these kind of oils that are very high in omega-6 fatty acids. This is a nice study that looked at different different animals and beef basically, and looked at their omega-3 versus omega-6 fatty acid ratios. And they noted that the pasture-raised or the grass-fed the grass-fed beef had a much better omega-6 to omega-3 fatty acid ratio. They were right there at 2 or 1:1, while the ones that were grain-fed, they were definitely higher, 5, 6, maybe even 10. So again, when you are going to eat meat, if you are going to be the person that is going to eat meat, make sure you eat the grass-fed animals. If you're in eggs, make sure that the organic eggs, because those do have a different fatty profile. So you got to walk the talk, right? You can't just say, hey, put all my patients on these anti-inflammatory diets and then go home and eat a pizza, all right? We need to be able to walk the talk. So this is an example. This is one of my breakfasts. I do that kind of breakfast almost every other day. The other day is gluten-free oatmeal with blueberries, right? Because blueberries increase our antioxidants. And we have to do that. We have to, instead of becoming in an oxidative stress in the morning, lunch, and dinner, we as practitioners have to live this life and make sure we live in antioxidant status. All right, let's get back to oxidative stress, right? So what about neuropathy, right? Who sees patients with neuropathy? I mean, 20% of patients with diabetes have neuropathy. It's ridiculous. Diabetes, as Dr. Tashner and Jose mentioned, it's such a growing trend in this country, and neuropathy is such a huge cost to our system and so painful. These people are coming in with burning feet. There's nothing that can be done to them, and all these medications usually fail. What is the oxidative status of these people? So this is a nice study looked at sciatic nerves from rats, and they looked at their oxidative status of those nerves. And basically, the nerves of diabetic rats had oxidative stress. They had less antioxidants, and they were not functioning as well. They had neuropathy. So now, when they gave them antioxidants and they improved their antioxidant status, these nerves started working a little bit better. Doing EMGs on them, they actually were better. When they measured the blood flow to these nerves, guess what? The blood flow was increased to these nerves. And we know when the blood flow is increased to the nerves will heal. So what about people, right? We don't treat rats and mice. Can people with diabetes and neuropathy benefit from antioxidants in their body? So this study looked at patients with diabetes and neuropathy, and basically we noted that, let's look at one of the oxidants, superoxide. Control is 2.56, but if you look at patients with diabetes and neuropathy, 5.17, doubled. So these people are in a lot of oxidative stress, and that is contributing to the disease of their nerves. So what do we do in our clinic? How do we treat neuropathy? We put them on vitamin G, right? Who knows what vitamin G is? Vitamin gabapentin, right? Everyone that comes into my clinic is on vitamin gabapentin or vitamin Lyrica. It's like the perfect, and then they come in and like, yeah, I don't remember things anymore. I got lost to your clinic. I ended up somewhere else. There's a patient I just saw yesterday, yes, Friday, yeah, yesterday, and he came into my clinic originally. He was on gabapentin 600 3 times a day. We had him down finally to 200 once a day, and we're slowly getting him off. But he said he didn't know where his life was. He was constantly zoned out. He was a zombie. So is that the treatment for diabetic neuropathy? Do we make them into zombies? And it doesn't really work as well as we think it does. So in our clinic, we put them on a diet. We use the Nutritarian diet. I like this one a lot, Dr. Fuhrman's book. He's a vegan, and he promotes the vegetarian diet, but he does allow for some meats and some fish. So we use his diet, again, with our therapists, promoting it as well. Very high in nuts, beans, and berries. A lot of antioxidants. Usually try to get them gluten-free too. And there's a lot of concepts behind it. I don't want to get into the gluten controversy because we could spend a whole day on gluten intolerance. But Dr. Alessio Fasano did some really interesting research. I think he's from Harvard, and he looked at the gluten proteins, the gliadins in the gluten proteins, and noted that the immune system sees these gluten proteins and develops antibodies, and then it looks at the nerves and, hey, there's a protein very much like the gliadin protein, and there's this mimicry going on. Your immune system actually starts injuring your nerves. So very often patients with celiac disease have severe neuropathies because their body's attacking their nerves. So that's why we, in our clinic, we use a modification in gluten-free diet sometimes in the treatment if we feel it's appropriate. Not everybody needs to be gluten-free, but sometimes it is the appropriate thing. And we also eliminate their neurotoxins, like pesticides, so we ask them to eat organic, alcohol, other drugs. We use some vitamins and minerals like CoQ10 or alpha-lipoic acid, as Jose mentioned earlier, and sometimes we do different types of injections, but these patients get better. So here's a case of a patient with neuropathy, 33-year-old female, numbness, burning for 1 year, chronic back pain, headaches, GERD, IBS, painful abdominal scars. I have pre-diabetes. She came in, there we go, 300 vitamin G, 300 milligrams 3 times a day on a PPI, on Furoset. Horrible diet, eating lots of sugars, snacks, no fruits and vegetables. We did an EMG on her, which showed that she had sensory motor neuropathy. So our plan, we put her on a Nutritarian gluten-free diet, stopped the soda, tea, snacks. We put her on a vitamin B complex, did some physical therapy with Super Nancy, another one of our therapists who, again, uses food as medicine as part of our clinic. Did some scar treatment. 3 months later, her neuropathy was gone. I tell my patients, you can wake up in the morning and say, do I like neuropathy or do not want neuropathy? You can make that choice. So her neuropathy was gone in 3 months. Her lost 25 pounds, back pain was about 90% better, headaches 50% better, GERD and IBS resolved. She's no longer on a PPI, and she's off most of her meds. So we use a lot of other things to help increase antioxidant status in our patients. We use tart cherries or tart cherry juice in our patients. It's been studied for multiple things, for gout, for myalgia. This is a nice study that looked at marathon runners and looked at their oxidative stress and their inflammation after marathon. And the people the runners that were on tart cherry juice, they had less oxidative stress and they had less inflammation afterwards. And there's another study that looked at another group of patients, and these people actually had less pain. So if you look at the people on the tart cherry, after the race, their symptoms, their VAS scale was a lot less, 22 compared to 45, which was on the placebo. So huge. Not that everyone needs to be on tart cherry juice, and we don't have our diabetic patients drink an 8-ounce glass of tart cherry juice twice a day. Absolutely not. It does have sugar. We usually have them put 1 ounce or 2 ounces of tart cherry juice in the water and drink it throughout the day. So it limits the amount of sugar, but it still gives them the antioxidants. It gives them the melatonin. It's, again, we're improving their antioxidant status. So what about tendinopathies, right? So how many therapists do we have in the room? Do we have some physical therapists? So you're dealing with tendon issues all the time, right? So this was a study in one of the physical therapy journals, and they looked at patients with tendinopathy, 40 recreational athletes for 3 months of tendinopathy, and they put them on ultrasound, some physical therapy, and placebo, or ultrasound physical therapy, and a whole lot of antioxidants and omega-3 fatty acids, which we looked at that are anti-inflammatory. And guess what? The patients on the placebo, they got better, of course. We did physical therapy, so they are going to get better. But the patients on the antioxidants did even better. And at the end of the study, they were up to 97% of their pre-injury physical activity and running and exercise activity versus the other one only about 69. So they improved their recovery with the antioxidants. So where do we get these antioxidants, right? Do we get them from pills? No. We get them from food. As Dr. Tashner said, when you get it from food, it's like drinking or eating that whole orchestra instead of that one musician. We really get an orchestrated array of nutrients that your body assimilates and uses to help you. So, we got foods like beans and blueberries and cherries and cranberries. Those are very high antioxidant foods. That's why, again, in the morning, I eat my cereal with blueberries. So what happens when we process these foods? So I have a question to ask. How many of you do not peel your cucumbers? Good. Because not peeling, it actually maintains the antioxidants in them. So if you look at the peeling of cucumbers, if you peel them, you lose about 50% of your antioxidants. So why are the peels, why are the outer parts of these vegetables so high in antioxidants? What do you guys think? It's because that's where the vegetables and fruits are protecting themselves. That's how, as Jose said, these vegetables are stressed by the things that want to attack them, so they need to be able to protect themselves. And just like we use antioxidants to protect ourselves, fruits and vegetables protect themselves with antioxidants as well. And they do that in their outer layer, in the peels, right? So freezing and freeze-drying has also an effect. When you freeze fruits and vegetables, it actually doesn't really decrease their antioxidants. So I have a lot of patients say, well, I can't eat fruits and vegetables every day because I go to the store once or twice a month. Well, you can get frozen berries, frozen vegetables, frozen fruits. They're still okay. They're still high in antioxidants. So now when we eat these foods, do they actually get into our system? Do we get these antioxidants in our blood? And yes, they definitely do. Here's a nice study looking at eating different fruits and vegetables. So here is eating just a regular meal, and your antioxidant status goes down. But if you eat the blueberry powder, your antioxidant status actually goes up. And the nice thing about this study, what I like to point out is, if you eat the fruits, the whole fruits, your antioxidants go up for 3, 4, 5 hours. So again, instead of going into oxidative stress for breakfast, lunch, and dinner, if you're eating these fruits and vegetables, your antioxidants go up. The powder, though, is interesting, only brought them up for about 2 hours. So again, it's the real food. We want to eat the real foods, as Jose and Brian said. Eat real, raw foods because it makes a difference. So breakfast, lunch, dinner, I'm in antioxidant heaven all day. So Jose mentioned this again. Quick little note on that, organic versus conventional. Organic vegetables have more antioxidants because, as Jose mentioned, they are stressed by these bugs, and the way to protect themselves, they make more antioxidants. So these conventional vegetables and fruits, they're protected. They have, they're probably genetically modified, and they're sprayed by Roundup. So they're like, hey, I don't have to worry about anything. I'm just going to grow into large vegetables, large fruits, right? And that's all they have to worry about. And that's why our organic vegetables and fruits sometimes look a little bit smaller, right? They're not as big because guess what? They don't have all the time to focus on growth. They have to focus on, I need to produce antioxidants to protect myself. And then we eat those antioxidants, right? So let's review again. Oxidative stress is involved in chronic pain disorders. You guys agree? It's there, and there's a lot of studies behind it. Antioxidants can decrease antioxidant stress and pain symptoms. So food increases antioxidants in our body, and then food can actually alter the course of your pain disorders. Another case, this is a 17-year-old female that came to my clinic, widespread pain. It's been going on in her neck, shoulders, back, present for about 1 year. No injury, was in a high exercise military training program, the ROTC. She started some physical therapy afterwards. It didn't really help. Had insomnia, constipation, joint pains, acid reflux. It was on a PPI. I went to multiple specialties and was told she's got fibromyalgia. And basically, they put her on vitamin G, of course, my favorite. So she came in on vitamin G 4 times a day, 300 milligrams naproxen, pain all over the place, 6.5, worst was 9 out of 10, And sometimes she needs to be in bed because she's in so much pain. And this is a 17-year-old girl who 1 year before was healthy, active. Well, healthy, we'll talk about that. But she was definitely active. Very poor diet. Ate pizza, soda, juice, candy, not much for breakfast. And her family was kind of like that too. Her father was another chronic pain patient from another clinic. He was also on gabapentin, vitamin G. So hey, the whole family is on vitamin G, right? So we're going to treat this girl. We're going to make her better. We had a beautiful plan for her. She was in major oxidative stress. We're going to start her this morning with a green smoothie with protein in the morning, right? Really try to rebuild that mitochondria that Jose talked about so much. Put her on a nutritarian, gluten-free diet, gentle yoga therapy. People with fibromyalgia don't do well with an aggressive physical therapy because, as Jose mentioned, their mitochondria are shot. They can't tolerate it. So gentle yoga therapy. We were going to supplement her with some magnesium, some vitamin D. She was pretty pale. And then we were going to slowly taper off her meds. I'm going to read this. This is a note from the chart to the primary care doctor. The father called today, very upset with the pain consult. The doctor wants her to change her diet. She does not like fruits and vegetables. What is she going to eat? She's going to college soon, does not have time to make these changes. We need something now. She needs a better medication. And we see this every day in our clinic. Perfect example, beautiful plan. We can't execute it. So I looked at her chart actually before our last conference in January. 9 months later, still in pain. She was on gabapentin. Now they added Zenaflex. Beautiful. Difficulty with college. She started in college. She was now diagnosed with ADHD and started on Concerta. And she was looking for another rheumatologist to fill her medications. Sad but true. So food can hurt, but so can our medications. As Jose, he had a whole list of medications that can affect our mitochondria. Statins and fibrates, I have a problem with that every day because, again, the clinic that I work, I see people who are in pain, and medications can hurt. I had a patient last week who came in who has been being treated for back pain and hip pain and leg pain for several years. She was told she's got spinal stenosis. She had epidural injections. Her pain was worse whenever she walked, but with rest she would get better. So she had a CAT scan years ago and it showed spinal stenosis. So we did, she actually came in with an MRI. So we looked at her MRI and the radiologist said the MRI was pretty much normal. No spinal stenosis, no neuroforaminal stenosis. The radiologist said it was a normal MRI. So we're looking at her MRI, and as I do with all my patients, we're looking at her multifidi and her spinal extensor muscles. And these guys were shot. Half of them were just fat. They had no spinal muscles to support her spine. I did her strength exam. She was weak in her hips. And she's been on statins for years. And I thought, hey, I think this woman has statin myopathy. So we're going to try to treat her as statin myopathy. We're going to get her off statins and get her on a really good diet to lower her cholesterol because she was worried about that. But this woman had no muscle in her back to support her back. So when she's walking there in the store, after a while, this muscle's fatigued and she's having severe back pain, hip pain. It's not because she had spinal stenosis. It's because she had no muscle. And why did she have no muscle? I have a feeling it was because of the long dose of statins. Other things can cause pain too. Constipation, irritable bowel syndrome. In my clinic, we treat the gut a lot. People come in for a spine consult, yet we're talking about their poop. But it's common. People with constipation, that stool can press on those nerves and cause back pains, can cause sciatica. Diverticulitis can do the same thing. Visceral pain, your liver can cause right shoulder, right neck pain. Stomach can cause left shoulder, left neck pain. There's a lot of things that are food-related diseases that contribute to pain diseases. So when we see a patient, we have to look at the whole patient and look at their poop, look at from their toes from their brains to their toes, and see where is their pain coming from. So I'm going to finish off. Here's a picture of my son and myself. We're eating breakfast, and there's some superheroes right here on his breakfast table. And when we eat the breakfast, this is our superhero breakfast. We have lots of vegetables, some organic eggs, and I'm teaching my son to eat superhero breakfast. And I'm going to leave you off with the same concept. Teach your kids to eat superhero breakfasts. Thank you.